Next, we have Dr. Kathy Tran. Dr. Tran recently graduated with her PhD from UC Berkeley's Environmental Health Sciences program. Her dissertation explored the potential health and environmental implications of oil and gas development in California. She applied biostatistics, epidemiology, and spatial analysis methods to investigate the relationships between maternal exposure to oil and gas development and birth outcomes, as well as characterize potential water-related risks. Welcome, Dr. Tran.
Hello, my name is Kathy Tran. Thank you so much for giving me the opportunity to share with you about my research. So what I'm going to be providing an overview with through this presentation is a study that's part of my dissertation and has been published by Environmental Health Perspectives. So the study is titled Residential Proximity to Oil and Gas Development and Birth Outcomes in California, a retrospective cohort study of 2006 to 2015 births. And a lot of the background that I'll be sharing echoes what both David and Dr. McKenzie have spoken about. So first, oil and gas development in California is a long-standing industry. And up until about 2016, California has remained one of the top 3 producers of oil in California. California is a little bit different in terms of the oil and gas development landscape in that we mostly produce oil as opposed to gas, and also the wells are mostly conventional wells as opposed to unconventional wells. And yet there hasn't been any studies conducted in California until David and I both published our studies. So real quick about the various routes of exposure related to oil and gas development, as I'm sure you've heard through multiple presentations, but quickly, so some of the pollutants such as particulate matter and benzene coming from wastewater can have some potential direct health impacts if they are inhaled or ingested, whereas some of the other routes of exposure such as noise and excessive lighting can lead to stress, which then may have long-term health impacts further down the road. So again, a lot of the studies that focused on health outcomes, many of them happen to be focused on birth outcomes. And as Dr. McKenzie mentioned, fetuses are a very vulnerable population, and also adverse birth outcomes can have longer-term effects as well. So among the studies that were published prior to mine, they focused on preterm births, fall for gestational age, low birth weight, and decreased birth weight. And those are the outcomes that I also looked at in my analysis. And approximately half of these studies showed that there was a significant increase in the risk for these adverse birth outcomes and decreased birth weight. I would like to note that, again, there are many differences in terms of the study design and also the location, as prior to this, the studies were conducted in Pennsylvania, Colorado, and Texas. They use various types, they define their control groups and the exposure definition different from each other, and they also applied slightly different statistical methods. So now moving on to my specific studies. So I conducted a retrospective cohort study, meaning that I used historical data in order to look at the relationship, which is my research question, the relationship between prenatal exposure to oil and gas development and birth outcomes in California. I was also interested in looking to see whether or not the associations varied by urban or rural community type. And my hypothesis was that prenatal exposure to oil and gas development increases the risk or the likelihood of the adverse birth outcomes. And I applied linear and logistic regression in order to explore these relationships. So the birth records were derived from the California Department of Public Health, and then the well records were, I acquired them from the California Department of Conservation. My model included both individual level and area level covariates. The individual level came from the birth records, and the area level included data sources from the US Census, the Center for Air, Climate, and Energy Sources, which publishes estimates for air pollutants, and the California Air Resources Board. My study population consisted of births between the years of 2006 to 2015, with maternal exposure between 2005 to 2015. From all the births across California, I then narrowed down the study population to approximately 2.9 million births within the Sacramento Valley, the San Joaquin Valley, the South Central Coast, and the Southern California. And these particular air basins were selected because, as you can see on this map, this is where most of the oil and gas activity was happening and is currently happening in California. And additionally, I only selected births to mothers that had at least one well within 10 kilometers, which is about 6 miles, of their maternal residence. And the reason why I applied these inclusion criteria was to ensure that the people who were exposed and not exposed were relatively similar to each other, except for their exposure status. So the birth outcomes that I looked at was low birth weight, again defined as having less than 2,500 grams at birth, preterm birth, which is before 37 weeks, small for gestational age, meaning that birth weight is less than the US sex-specific 10 percentile of weight for each week of gestation. And finally, term birth weight. So I only looked at those that were born after 37 weeks, and the birth weight was in grams. For my exposure, this was defined based on two well types, one being active and the other being inactive. So for the active wells, I looked at the total production volume, whereas for the inactive wells, I did a count of those wells. Now, more specifically in terms of how I defined my exposure. So again, we're starting with a population that consists of everybody that has at least one well within 10 kilometers. And exposure is based off of a 1 kilometer buffer around the maternal residence. So anybody that had at least one well within, regardless if it was active or inactive, within 1 kilometer, then they were considered exposed. And those that did not have any wells within the 1 kilometer buffer, they were considered unexposed. So more specifically about my exposure metrics, so I had two, and they were both included in my models. For the active wells, I looked at total production volume, and I generated this metric by summing the monthly production volume from both oil and gas wells. And since the units of the gas wells is different from the oil, I converted that to barrels of oil equivalent in order to do the summation. And I further categorized the metric into 3 categories, the reference being no production volume, moderate having 1 to 100 barrels of oil equivalent per day, and high meaning that they had more than 100 barrels of oil equivalent per day. And this is specifically to across within a mother's pregnancy. Now for inactive wells, again, I looked at the total count of inactive wells within 1 kilometer, and I categorized this particular metric into 4 categories. The first being referenced with no inactive wells, low having 1 inactive well, moderate having 2 to 5 inactive wells, and high having more than 6 or more inactive wells. So in terms of how I looked at the relationship, again, I used regression models. So the low birth rate, preterm birth, and small for gestational age were all binary, meaning that it's either you have it or you don't. And I applied logistic regression in order to assess that relationship with maternal exposure to oil and gas development. And then for term birth weight, it's continuous. So I used linear regression in order to perform that analysis. And within my models, I accounted for clustering within census tracts, since people who live within the same area are more likely similar to each other than people who are in different, further away census tracts. And additionally, in these models, I also adjusted for individual and area level covariates. The individual level covariates were the child's gender, birth month, and year. And for the mother, it was her age, race, ethnicity, education, a metric for adequacy of prenatal care, and whether the mother had a previous birth or not. In terms of the area level covariates, I included the air basin, urban rural status, and nitrogen dioxide concentrations, which is a proxy for traffic, as well as a metric for income inequality. So now I'll be sharing, highlighting the major findings from my analysis. So to orient anybody who, and again, David has already done so, but I would like to again reorient anybody who may not be familiar with interpreting odds ratios and mean differences. So for the reference here, we have the reference for odds ratios is 1, meaning that if the point estimate or the confidence intervals include the reference line, then that suggests that there isn't a statistically significant difference between those who are exposed versus unexposed in my particular analysis. And for the birth weight analysis, the reference there is 0. So that means that if the point estimate or the confidence interval includes 0, then there is no difference in terms of birth weight between those who are exposed and unexposed. And then also for the results I'll be sharing, you'll be looking at the differences between urban and rural community types. So in these models, I did not include urban rural status I did not adjust for that in my these models because I had stratified by urban and rural status. So first, let's look at low birth weight. And what I see there, the major finding here is that among the rural population, we observed about 40% increase in the likelihood or the odds for low birth weight among those who were exposed to high production volume compared to those who were unexposed. And however, when we look at the urban population, we observed no effect there. Moving on to the preterm births. So here, as you can see, these estimates and confidence intervals include the reference value of 1. So here, this suggests that I did not observe any strong relationship between preterm birth and exposure to active well production volume. Now, moving on to small for gestational age. So here we also, among the rural population, we observed approximately 20% increase in the likelihood for small for gestational age among those who were exposed to high production volume compared to unexposed. And among the urban population, there is a modest increase in the likelihood for small for gestational age with exposure to high production volume. And finally, when we're looking at term birth weight, among the rural population, we observed a decrease of 36 grams in the term birth weight among those who were exposed to high production volume compared to the unexposed. And for the urban population, again, this point estimate also is at the reference, suggesting that there is no strong difference between those who were exposed and compared to the unexposed. And then now, in terms of the exposure to inactive wells, overall, if you look across the 4 different birth outcomes and also the different levels of exposure, different levels of counts of inactive wells, For the most part, the estimates include the reference value of 1 for the odds ratios, or 0 for the term birth weight. And for anything that was significant, the estimate was very modest. And for that reason, we concluded that overall, it seems that perhaps exposure to inactive wells does not have a strong relationship with adverse birth outcomes. So in summary, higher exposure to higher production volume from active wells is associated with the increased odds of low birth weight and small for gestational age, as well as decreased term birth weight, especially among the rural population. And highly productive wells in rural areas may pose the greatest risk. My results were robust in that when I conducted sensitivity analysis with other sources, I adjusted for other sources of pollution and maternal risk factors, the effect estimates did not change very much. So why do we think it might be adverse birth outcomes be related to exposure to active production? So in previous analyses, studies, they have observed that there are elevated levels of pollutants such as toluene and benzene at wellheads, as well as sites that are around where active production is occurring. And there's also excessive noise to the level that can induce stress and also interrupt sleep. And so these various combinations of routes of exposure to active production may be contributing to the observed effects. And also, as you saw, the effects were also much stronger in rural areas compared to urban areas. So one of the explanations might be that in rural settings, oil and gas development may contribute a greater proportion to the overall air pollution, local air pollution in rural areas compared to urban areas. And also people who live in rural areas may be more likely to consume well water that has a higher chance of potentially being contaminated by oil and gas development. I do want to remind you that we did observe some modest effects for small for gestational age in urban areas. So oil and gas development may still have some health implications for those residing in urban areas. So my study has both some limitations and strengths. In terms of the limitations, I was not able, because I did not collect any air samples, water samples, I was not able to identify what particular exposure pathway might contribute to the observed findings. There could also still be some unmeasured individual and area level confounding, such as other sources of pollution that I had not considered to adjust for in my models. And there could also be additionally, there might be exposure misclassification due to maternal, residential, and occupational mobility. For example, mothers may not work where they live, and if they're spending more time where they work, then maybe they're not as exposed to oil and gas as we think. In terms of the strengths, my study is one of the 2 first studies that were published on this, on adverse birth outcomes and oil and gas development in California. And I also had unique exposure metrics in that in my models, I simultaneously modeled both exposure to inactive and active wells. And also these wells tend to be co-located. So by adjusting for one or the other, I can, kind of sift through the potential influence of whether it's inactive or active wells. And additionally, I also looked at the differences between urban and rural settings, as many of the previous studies were conducted in rural areas. And so this does suggest that there may be some implications for urban areas as well. And finally, my research informs some regulatory decision making in that regulators may want to consider increasing their efforts to monitor air and water in and around wells, as this suggests that there may be some potential health impacts, and also update the current setback distances. And as they're making their decisions, they also should probably consider sensitive populations such as pregnant mothers, and address some of those potential concerns. And finally, they should also consider, as the regulatory agencies, I know that they are conducting many studies, and so they should also consider adding production volume into their future analyses. My paper, again, can be found on the Environmental Health Perspectives Journal, and this is an open source, so anybody can access this paper. And with that, I'd like to thank my co-authors, as well as those who provided me with advice and funding along the way. Thank you.